Alrighty, so welcome. On behalf of Girl Scouts of Southwest Texas, I am Stephanie Finleon-Cortez, and I'm the Chief Development and Communications Officer for the organization. So we want to welcome you to session 4 of our It's Our World, Change It virtual event series, where we've really taken this month to explore racial disparities, looking at our history and how we got here, and then really taking a deep dive and looking at racial disparities in education, the economy, and today we're going to focus specifically on healthcare. So we have an excellent panel of phenomenal women who are going to share their expertise with us. Before we get started, I just want to remind those of you who may be new to this platform, as you come into the meeting, you are automatically muted. So I'm going to ask all of our attendees to keep themselves muted so that the presenters are able to speak. If you've got questions or want to make comments, please use the chat feature. We'll be monitoring that, and then we'll also pull questions from that at the end of the session. So if you need anything or you have any troubleshooting, please feel free to send a message in the chat. And then at the end, when we get to the Q&A session, if you would prefer to speak, you're welcome to unmute yourself at that time and ask a question of our panelists. So in the meantime, let's go ahead and get started. I'd like to start by introducing our moderator. Let me let some more people in. So our moderator today is Marilyn Stanton-White, is a retired healthcare professional with 30 years of experience in healthcare administration, specializing in ambulatory healthcare services, nonprofit healthcare, fund development, board relations, and diversity. Before her retirement, Marilyn was Director of Clinic and Behavioral Health Services for Methodist Healthcare Ministries for 15 years, was an adjunct professor for Our Lady of the Lake University, and is a Life Fellow of the American College of Healthcare Executives. A veteran, retiring as Major from the U.S. Air Force, Marilyn remains active in the community as a past chair of the African American Advisory Committee for Girl Scouts of Southwest Texas, and is president of the 90-year-old Alpha Tau Omega chapter of Alpha Kappa Alpha Sorority Incorporated. So Marilyn, thank you so much for agreeing to moderate today's discussion, and I will let you take it away and introduce the rest of our guests.
Thank you, Stephanie. It's so great to be here and to be with the Girl Scouts today. I'm really looking forward to this. So first, I'd like to introduce you to our panel of experts. First of all, there's Dr. Karla Acosta-Monroe. She's a third-year resident at UT Health San Antonio, where she is appointed as a chief resident. Her passion for medicine developed at a young age as she witnessed firsthand the health disparities within her town and her own family. During her time as a medical student, she founded a Latino Medical Student Association, LMSA chapter, where she helped restructure REACH, HEI, a mentoring program that provided mentorship and science education to underrepresented high school students. Those experiences profoundly reinforced her commitment and desire to provide quality health care to underserved populations. That also encouraged her to pursue her family medicine residency and to become a patient-centered clinician and public health educator. Dr. Clarissa Aguilar is a behavioral health consultant at the Center for Healthcare Services in the Integrated Care Primary Care Clinic. A native Texan, Dr. Aguilar has worked in integrated care settings for more than 10 years and is traditionally trained clinical psychologist. She earned her doctoral degree from Texas A&M University and completed her pre-doc internship at St. John's Child and Family Development Center in Santa Monica, California. Her dissertation studies focus on factors that predicted utilization of prevention intervention services and increasing access to those services, especially for the Latino population. Dr. Aguilar is passionate about integrated care and believes in its role as a means of equalizing health disparities and as a mechanism of social justice. Dr. Ruth Morgan is a medical director of primary care for the Center for Healthcare Services and the medical physician at Project Health, Homeless Engagement Addressing Limitations to Healthcare, the integrated courtyard clinic on the Haven for Hope campus. She's passionate about community medicine, working with the underinsured and global health. Dr. Morgan has participated in medical mission trips and education in Fiji, China, and Uganda. She's a member of the Gold Humanism Honor Society. Most recently, she was selected to serve on the Bexar County Ryan White Program Quality Management Committee. Thank you very much to all of these esteemed women that are with us today. And so Dr. Morgan has a few definitions and demographics she'd like to share with us before we get into our question section. Dr. Morgan?
Well, thank you all for having us. You know, I think this is a really important topic that often organizations shy away from. So I really congratulate you with sort of confronting those issues and really taking a deep dive. I've seen sort of the itinerary for what you've been doing this past month. And so I'm really just in awe of your organization for taking a look at those things. So first, let me share my screen. I'm going to do this. So let's see if I can, yay, okay. So one of my favorite quotes is, of all forms of inequity, injustice in healthcare is the most shocking and inhumane. Right? So a quote from Martin Luther King, and we see that often in our society. So I just wanted to begin with some definitions so that we all sort of know what we're talking about. So first, a health disparity. So what's a health disparity? It's a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantages. So health disparities adversely affects group of people who have systematically experienced greater obstacles to health or healthcare based on their racial or ethnic groups, religion, socioeconomic status, gender, age, mental health, which we see all the time at the Center for Healthcare Services, cognitive, sensory, physical disability, sexual orientation or gender identity, and geographic location, or any other characteristics historically linked to discrimination and or exclusion in the US. Now, healthcare disparities are a little different, but it encompasses health disparities. And healthcare disparities are racial or ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, or appropriateness of an intervention. So we'll be talking a lot about that today. And then sort of talking about health equity and health social justice. So health equity is the attainment of the highest level of health for all people. Achieving healthcare equity requires valuing everyone equally with focus and ongoing societal efforts in addressing sort of avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. And so we've seen a lot of that in the news nationally recently. But I just wanted to take a few moments to focus on San Antonio. So, you know, if you look at Bexar County by zip code, it's amazing that life expectancy can vary wildly just based on zip code within the same county by 20-something years. So the lowest life expectancy in Bexar County is 67.6 years. And that's in zip code 78208, which is the Governmental Hill near East Side areas of Bexar County. So those are those dark brown areas that you see. And then the highest, which you see is this blues here, dark blue, is 89.2 years. That's a vast difference. And you see that on the northwest side in the area code 78254. So life expectancy, that discrepancy by almost 20 years in Bexar County is hard to explain, right? We're all in Bexar County, and we're going to sort of talk about some of that today. So, Marilyn, I'm giving it back to you.
All right, thank you, Dr. Morgan. So one of the things that I would like to ask, and maybe the group would like to know, is that what are the most prominent disparities that you see in healthcare? And I'll give that question first to Dr. Aguilar.
Hello, and thank you, everyone. You know, one of the most prominent healthcare disparities, and obviously as a clinical psychologist, I do feel like mental health is one of the biggest disparities in our access to mental health services. Unfortunately, what we know about our healthcare system is that large disparities exist not only in mental health, but also across other chronic health conditions. Unfortunately, ethnic minorities tend to suffer from a much higher rate and prevalence of chronic health diseases and conditions. And I'm sure Dr. Acosta-Monroe could probably speak more to that too. But what I will say is that at least for mental health, access to services is severely compromised in the ethnic minority population. I don't know if Dr. Acosta wants to talk to the health conditions.
Yeah, absolutely. Thank you so much for having me as well. It's such an honor to be part of this panel. You know, I grew up, you know, in a border town. No one's, you know, very small. We had to travel at least an hour or so to have some sort of medical care. The medical care that we did receive in Nogales was not quality medical care. But as, you know, I progressed through my career and ultimately here in residency, ultimately, you know, we've seen all these health disparities and how multiple factors contribute to a patient's health. And one of the main, you know, health disparities here in San Antonio obviously is access to care, but we've seen how disproportionately African Americans and Latinos don't have access to care, and not just by choice. Most of them are not insured, and also not by choice. They work full-time jobs, but most of their employment does not provide any health insurance whatsoever. I've noticed here in San Antonio in our clinic, everyone has diabetes, hypertension, heart disease, which could easily be prevented if we had access to care, if we had those preventative services. I think it's just a world of different things that have been impacted, like different factors that can impact, you know, our certain populations. But I've seen even like traumatic events, violence, incarcerations. Like I worked at the JDC, the Juvenile Detention Center, and, you know, I don't know, most of you guys have heard of the adverse childhood experience and how a lot of, you know, prior to the age of 18, a lot of these children experience all these adverse experiences, and ultimately that kind of just contributes and puts them at a higher risk of developing certain things. And a lot of the children that we have, not even children, you know, adolescents at the JDC, they're essentially born into this system. And I feel like most of us physicians try our best to care for everyone, but I think one of the factors that sometimes is not really conscious is implicit bias. And I think that's the main factor that contributes to all of these health disparities, that we consciously don't mean to not treat our patients differently, but we are a product of our environment and our culture. And when you have these stereotypes and these prejudice, you know, this is when it develops, you know, it's an unconscious behavior that we all have. But yeah, that's all.
Thank you very much, Dr. Acosta. I actually had a few questions, and I think you answered almost all of them. But one of the things I wanted to ask, and I think perhaps Dr. Aguilar can answer this, or maybe with Dr. Morgan's help and your help, Dr. Acosta. is integrated care. And I think we know, or should mention, that culturally, both Latino and African Americans do not tend to want to go to a psychologist or a psychiatrist. You know, I'm not crazy, you know. And so how do you think that culture prevents us from being able to have our integrated care with our medical care, family medicine, and our mental health?
Thank you so much for that question. It's something that's very close to my heart and something I feel very passionate about. I guess very much like Dr. Acosta, I grew up in a border town where we had really limited access to all sorts of services, medical services, but specifically mental health services or psychological services. They were kind of unheard of when I was growing up. Which I think is a very cultural thing. A lot of Latino families tend to manage problems or issues or challenges within the family context and use family resources, extended family members, clergy, and other networks to help resolve family issues. So what I loved about learning about integrated care is that it brings mental health and behavioral health services into the primary care world and into medical settings. And this really allows families to access mental health intervention, evidence-based intervention, and to get help with health-related behavior change at the same time that they're visiting their primary care physician. So that creates a really wonderful way to dovetail on to medical services. And for too long, I really feel for too long, our healthcare system has divided psychological services and mental health apart from physical health. I've heard people say the medical system is only addresses things from the neck down and never really talked about the emotional or the brain part of our health. But integrated care is this very nice integration of physical and medical care that occurs together with mental health. And as a psychologist, I'm a primary care psychologist, so I get to work together with Dr. Morgan and with other primary care providers. When there is a mental health or behavioral health issue that comes up, I'm able to address it in the moment with the physician's assistance. So I really do feel that this is the future of healthcare. I really do feel like the way that we will be addressing mental health in the future is through this primary care behavioral health model. It also, as Dr. Acosta mentioned, it really helps us identify and work towards prevention and the prevention of onset of further difficulties. So if you can intervene early, if your primary care provider is providing that screening for the family, checking in with the family, primary care providers tend to have very long-standing relationships with their patients. We can get in early and really provide some good prevention. So I guess that Dr. Morgan, I know you have a few things you can probably add to that.
Yeah, well, thank you so much. So I kind of want to, I don't know if it's a good segue, but I would like to ask Dr. Monroe, because of some of these, the cultural issues that we have in the African American community and the Latino community, it seems that, and maybe the statistics actually tell us, is that we are disproportionately being affected by COVID-19. So Dr. Morgan, why do we think that is happening other than, well, I'll just let you answer the question. I'm so excited because I retired, 9 months ago, and now I'm like, oh yay, I'm back in the fold today. So forgive me, I don't want to answer the questions. I want to ask the question of you. So Dr. Morgan.
So, the CDC had a great article earlier this summer, and it was called Health Equity Considerations in Racial and Ethnic Minority Groups. And they were talking specifically about how inequities and social determinants of health, such as poverty, healthcare access, are affecting certain groups and sort of the interrelation of healthcare in those groups and their ability to seek care in COVID. So some of the things that we're seeing, one is when you think about social determinants of health and housing, a lot of folks of color are in or multi-generational households. So you have grandparents, parents, and kids all in the same household. So sometimes that could lead to crowded situations. So I know that we've had a patient who was willing to quarantine, but they couldn't quarantine in the house. So we had to talk to the city in order to get them into the isolation care facility that San Antonio has. But in that case, if that resource wasn't there, there would be no way for them to quarantine, and that would put more people at risk within that household. So that can be challenging. We're also seeing things like healthcare access and utilization. So a lot of folks, you know, if they don't have insurance, and we know that in Texas, we did not expand Medicaid. And I can go on for like hours about that.
Yeah, let's not get started.
Yes, but that inability to access health care at the right time can also have effects, right? So patients, well, I just feel a little sick and achy. I hope it's not the COVID, but if I go in, I'm going to get a big bill and I can't afford that. Or for our folks with occupational challenges, you know, racial and ethnic minority groups are disproportionately represented in sort of what we call essential workforce in those settings. So healthcare facilities, farms, factories, grocery stores, public transportation. So because of that, they're at more exposure and more risk for contact or being in close contact with the public or other workers who may be affected or sick with COVID. And then you also have to remember with COVID, you have a period, just like with the flu, where you're asymptomatic, right? So because they're in close contact, no one knows that they're sick yet. That also gives that disease an opportunity to spread sort of through the communities. And then last, I think I'm going to go with sort of educational and wealth gaps. And so when I say that, and you're like, wait, how does that affect COVID? But as someone, I think Dr. Acosta talked about earlier, with insurance, right? If people have jobs that lack insurance, then they're less likely to access healthcare. So it's all a domino effect.
Right.
In terms of COVID.
And then kind of along those same lines, then we have individuals who have other underlying illnesses that are not going to the hospital because they're afraid of COVID. So what is happening in that population?
Well, and you have to remember as a population, you know, racial and ethnic minorities just have higher incidence of things like diabetes, hypertension. And because of the inability to access healthcare, they may be more likely to be uncontrolled or to go sort of unchecked for a variety of reasons. So that also is playing a significant factor in sort of the disparities that we're seeing in terms of mortality and morbidity and COVID in those populations.
And I guess I want to ask, I'll go back to Dr. Acosta. One of the things I would ask you is that how is our overall public health affected by individuals that are uninsured? I think I had an opportunity once to talk to a neighborhood group, but their concern was that there's people that don't have insurance, but then they tie up the emergency room and they can't get in, but they have insurance. So how is that affecting the overall health in Bexar County that we have such a large portion of our population that's uninsured?
Yeah, so I'll just kind of give you like experiences that I've had personally. We have a lot of patients, most of our patients, we work at University Hospital. Most of them are underinsured or have CareLink. Most of the time, I believe it all contributes to the trust that they have in the provider and unable to establish a relationship with the physician that they feel comfortable coming back to actually receive care. I've seen that minorities, Black and Latinos, sometimes believe it's not necessary to go to the office. And also it's based on past experiences as well. There's an interaction that maybe might have contributed to them not feeling comfortable or feeling judged or labeled, then they were like, you know what, I feel fine. So a lot of these lots of preventative diseases, or even diabetes, it's a silent disease for a reason. It starts, damaging your kidneys, your circulation, your heart, and all these patients feel like, okay, I have diabetes, but I'm okay. Sometimes, they don't trust the health system for a reason, so they end up just going to the ED, and that's also not just an additional cost to the health system, an additional cost to the patient, but then the emergency rooms are saturated with patients. So what we saw, for example, in COVID, a lot of our chronic patients that we've been following, we hadn't seen in months because they didn't feel comfortable coming. So then we got the peak of COVID, and then after that, it's all these other patients that required medical care that didn't feel comfortable coming into our office, and then flooded our emergency rooms. But ultimately, I feel like, just based on my personal experiences, is just, feeling comfortable, feeling like they belong, feeling understood. And sometimes, we have patients, and I've had multiple patients that have diabetes. No one talked to them about what diabetes is or explained to them in their own language. So the use of medical interpreters as well is really important. So a lot of these patients, they're sick, they're chronically sick, they feel fine, and then it comes to the point where they have a heart attack, or they're in diabetic ketoacidosis and require emergency care. But that's something that I've witnessed myself.
Yeah, I understand.
Can I piggyback on that?
Sure.
Sorry. So, because you talked about a feeling of trust, and I just want to say that I know that historically, sometimes people and certain groups may hesitate to seek care because of distrust of healthcare systems. And I think we can't ignore sort of those historic things like the Tuskegee study of untreated syphilis in African-American males, or sterilization, which we've seen recently, of people without permission, right? And so, or when I worked in California, also in a border town, they were very concerned that if they came into clinic, ICE would come. And there would be times when ICE would raid the trains. So sometimes even things like that, just that mistrust of like government and healthcare systems becomes a barrier to care. And then because they ignore it so long, it just progresses to the point where they have to go to the emergency room because they, like Dr. Acosta said, they've had a heart attack now, they're in DKA. So I just want to also bring that up, that historical context, I think is important.
And I tend to think, although I'm not on the panel, but one of the things that maybe you can address is it seems like people that are in that particular population really don't think they're going to live past 60 anyway. They've been so used to members of their family, they pass away from diabetes or a heart attack at 60. I've been blessed, my family lives into the hundreds. And so in my mind, I'm supposed to live that long. So how do we kind of overcome some of those type, I guess we call it cultural or familiar barriers, because we're so used to it? Then why fight it? We're going to go at 60.
Thank you. Thank you for that question. Actually, this has just happened. This issue, this very issue that you're just describing, just came up in my clinic this past week. And I had to have a very heart-to-heart discussion with a patient who has had diabetes for a very long time, but has come to accept that this is her fate. She will die of diabetes the way all her family members have. And she is kind of willing and in some ways readying herself for this inevitable end. And hearing that really makes me think about the helplessness that this family has felt over the years. And it did get us into this discussion about trust of the healthcare system. And as we dove into that, I realized that this really was the issue. Everything that Dr. Morgan just talked about, just having some significantly negative and maybe racist experiences in the healthcare system has kept her whole family and generations of individuals out of healthcare. And so I do think one way of addressing that is to explicitly have this conversation with the patients that we see so that we can bring it to the surface and have it be acknowledged as a source of pain and as a source of distrust. I also think, a great point of connection that this patient and I had is that we were both Mexican American. She started using some Spanish words that I understood easily. I started using some Spanish with her. We do a lot of Tex-Mex here in San Antonio. And so she was kind of surprised. And she said, well, my uncle is a curandero, and we've had to visit him. And I said, well, that's great. That's good. Like, let's continue to talk about that. And she was so surprised that I was welcoming that information and was inquiring more about it. So again, I don't know, and I guess this kind of brings up an issue. It's exciting to talk to Girl Scouts and think about kind of the next generation. I think we need diversity in healthcare. And I think our medical education really needs to include and recruit and focus on people of color and people that look like our patient population. I think it makes a very big difference, and that's another way that we can address this issue. I was able to kind of speak the actual language of this patient, but culturally I had a familiarity as well with her cultural experience, and I think those things can help break down barriers.
Right. And I have, it's funny, people would look at me and not know that I've had the experience so much with the Latino population. And of course, I know what the curandero is. And that's very interesting also, because doctors, what do you think about the fact that here in San Antonio, we also have some immigrants from Africa, from South Africa, West Africa. We have about a 2% population of Asians. And so each one of those groups come with some of their own cultural expectations. So how are we addressing that in Texas and Bexar County to help these populations through their healthcare, the system? Dr. Morgan, you probably see some.
So, sorry, someone's trying to call me.
Oh.
So, and it's funny because there is like a student-free run clinic that specifically addresses the needs of immigrants, right? That we have in San Antonio. you know, there's language barriers, there's cultural barriers. And I think for me personally, you know, yes, I am a minority, but I am a minority of a few groups, right? But not of all groups. And so one of the things that I try to press upon for the residents that I teach is to try to learn from your patients, right? So it's not a one-way street of information. It has to be bidirectional. You have to learn from them as much as you may be teaching them about their diabetes. They're teaching you about their culture, their eating habits. You have to do that in order to figure out what's going on in their lives. So when I talk about those social determinants of health, you know, those are things that we need to dive into on like a daily basis in order to figure out the complete story of our patients. With not, then we're only getting part of the story, and we don't understand that so this is an example from one of the residents, when you gave that patient a medication and you put once a day, because we still write sometimes, but they read it as once, right? You may kill a patient, right? Or if you give a patient a medication that costs $400, but their rent is $700, and what they have coming in is $1,200, you literally have made the patient make a decision between, are they going to have rent? Are they going to be able to feed themselves? Are you going to label them later as uncompliant or non-adherent to treatment? And those are our faults, right? And so those are things that we have to understand about our patients in order to give them health equity and really great quality of care.
So doctors, I hear you saying that we need to focus on mind, body, and spirit in order for us to make it through this healthcare disparities. So what is going to be required locally at the state? We already know that the state would not expand Medicaid, so they eliminated a population that didn't have Medicaid and couldn't afford the Affordable Care Act. So we had a group there that were having non-availability, non-access to healthcare. So how are we going to fix it? What's crickets?
It's $1 million question.
Right.
I was going to say, I think that there are a lot of things, right? So Dr. Acosta had earlier sort of talked about sort of societal view a little bit. So, you know, one of the things that when I look at pop culture and I think of kids and I view that lens, what does it say to a kid if you're Latino and everyone you see is a maid or a gangster or a drug lord, right? Pablo Escobar, right? That is, you know, so what does it say if you're someone of Arab descent and everyone is a terrorist on TV, right? If you're an African-American male and everyone's a gangster rapper or a thug, right? So those things, I think, for our kids and self-worth really plays a role. And then I think often we try to talk about things in a vacuum without thinking about sort of our history, right? So our history in society really does play a role in how things are today. And I'm going to give you a great example. So when I applied to medical school, right, I applied, I have a friend who applied, we're both from Memphis. We both went off to college. So I went to school at Dartmouth, so I went to New Hampshire, he went to Middlebury, and we both applied in Memphis, to UT Memphis. So he got an interview, I did not. And so I called and I said, I'm sorry, this seems odd to me. right? We both sort of have the same scores, the same this, the same that. And I was told, well, you have lived outside of of Memphis or Tennessee for X amount of years. And I went, well, so did this person over here. Well, we can't talk about that person. But I knew the person's history. And I said something, well, I know his grandfather went there. Oh, his grandfather went there. That is why he more than likely got the interview. And I said, I'm sorry. At that time, you weren't even looking at people of color to come into your institution. So he was able to go to a state school. It was much cheaper for him, right? Because his grandfather went to that institution. There was no way that my grandfather was ever going, they probably wouldn't have even treated him at that institution. Right, and so that is an institutional system that has perpetuated, like that practice, some racial policies of preference that people don't often think about. So when we talk about grandfather clauses, that has real world effect today. And so I think that all of those things, and just lack of opportunity for times, right? If you think about historically, there was redlining. I know that was a different topic, but redlining and housing, right? The fact that if you moved to Oklahoma, if you were a person of color, they didn't allow you to own a house, right? So all of those things, and housing equals wealth, right? And so all of those things play a part and impact healthcare. I don't even know if I answered your question. I'm sorry.
Well, I don't know, as Dr. Aguilar says, I don't know if we can even answer the question. It's just been my life's work that I have wanted to fix it, and I know that in some ways it's virtually impossible. We're taking some tiny steps. But I guess what I would like to point out, and I hope that those that are on the call will realize that the Girl Scouts, I think, are doing a great job of providing that education and that self-esteem for young women who are coming along, to give them the opportunity to realize that they can get an education, they can learn to be entrepreneurs and selling. I just got a notice from one of my neighborhood children that it was time for me to buy nuts and candy. So she'll be knocking on my door soon. But that young lady has enough esteem, and she feels good enough about herself to even approach a person who's not her color in the neighborhood and ask for her to support her. So this is one of the ways that we can start in community. We have Girl Scout troops on all areas of the city, and I'm sure that all three of the doctors that we have on today would be welcome any chance to talk to those young women and voice their experiences, but show them how, look, you look like me, you can still go further than the west side or the east side or even the north side. Because here in San Antonio, we do have people that have low income that have been placed in housing on the north side, and they're even more at risk because they don't have facilities that will even take Medicaid or take care of individuals that don't have any insurance. So I guess we're getting to the point where we have opportunity for those that are on the call with us to ask their questions. So Stephanie, I think I'm going to turn it over to you. I'm going to thank Dr. Aguilar, Dr. Acosta-Monroe, and Dr. Morgan. So far, they've gotten me all excited again. So can we start taking questions from our audience?
Stephanie, can I share? Oh,
yes, please. Go ahead, Dr. Morgan.
so there's one other thing, and Stephanie has the link to this, but there's a national partnership for the Action to End Health Disparities, and they have a toolkit specifically for for community action. And they have a lot of great resources in here about, and also some educational tools when you're working with your young women. So I just wanted to share that and make sure that everyone has that information or has access to it.
Thank you, Dr. Morgan.
Thank you. We do have a question in the chat from Kaylee asking, how well does the healthcare system address that demographics experience certain illnesses differently? I've heard that complaints may be dismissed based on not fitting traditional criteria, with traditional in quotes. And I'll piggyback onto this too, especially I remember seeing like a Twitter thread where, you know, you had a lot of African-American women and Latinas who were sharing their experiences of going to the emergency room and being dismissed and not getting the care they need. Could you maybe give us a couple of examples of what that could look like as a lived experience for a woman of color? Anyone? Who wants to
Acosta talk. I know that she's a resident now and probably sees it a lot.
So, can y'all hear me?
Yeah.
Okay, sorry. No, I've witnessed like different experiences in my training where I've seen either women of color, like African American or Latinas, they come to the emergency room in labor, sent back home. Oh no, your contractions are not that off. Or, oh no, you're not in pain. So I feel like we're labeled, and I say we as, you know, a Latina, but minorities are labeled to be able to take on a lot. You know, for example, I'll give an example, like our sickle cell patients. They are in true pain, acute pain that require admission to the hospital and treatment with IV pain medications. They have a true disease, you know, their cells are sickling, and that's truly really painful. But being African American coming to the hospital, they're labeled most of the time as pain seeking.
Yeah.
And sometimes, you know, they just give them a couple, maybe a 1 dose of Dilaudid in the ED and then send them back home. And I have witnessed this with, for example, our cystic fibrosis patients who also have, and they're treated much more differently. And I feel that's, you know, that implicit bias that we have as physicians that needs to change. But that's one of the experiences that I've had in my training.
And it's very interesting that you brought that up, because for my ethics dissertation, that's what I actually talked about in medical school, was sort of the difference in treatment that I saw in sickle cell kids versus CF kids. So, and also the expenditure of monetarily that would happen between those two groups. There was a great divergence. So thank you for sharing that one, because I think that's one of the ones that always comes to my mind.
I also just wanted to kind of pipe in and say that, you know, I know that, you know, as a whole, we are trying to solve this issue and equalize health disparities. But the issue that Dr. Acosta has just touched on, I think, you know, we talk about making these baby steps. And so I do think one of these baby steps that we can make across medical training, and not just for physicians, but also for nurses, for psychologists, for any kind of healthcare professionals, is to get implicit bias training. I think that needs to be kind of something that is done across the board and becomes part of what training becomes. Just as important as it is to, for me, you know, learn how to do a clinical interview, I should learn about implicit bias. And I also think that and I think it's starting to happen, that the healthcare system really does have to focus on the social determinants of health and trying to address those in the healthcare system. We're kind of on the forefront of that, but I do think those are two major steps that could really help get us on the road toward equalizing health disparities.
And since we have a panel of all women here, would you find that since we are all women of color, that we have the double whammy when it comes to that. Because when, and maybe it's triple because I'm a veteran as well. And certainly we find that male veterans seem to be taken care of on a different level than female veterans. So are you seeing that, or any change that may be happening in medical school? Maybe Dr. Acosta, since you're in residency, are they addressing those types of disparities?
Yeah, I believe they are. I've received, as a Latina, first generation, graduated high school, went to college, medical school. This whole journey has been like uncharted waters for me. I've literally had to pave my way the entire time. But there's a lot of encouragement to get minorities in medicine and retain them, because the system is not designed for us. From the MCAT to, the standardized testings of the step 1, steps 2, step 3s, and the cost of education. I've witnessed firsthand, especially here in my residency training, one-on-one support and encouragement to not only excel in my training, take care of my patients that are like so dear to my heart. I love working with the Latino population, and that's why I want to stay in San Antonio. But they've also kind of provided that encouragement support, because they know, as minorities in medicine, we don't have all that support from families. I don't have anyone in my family or anyone that I know that is a physician. So I feel like there's been a lot of encouragement, a lot of programs. I've received scholarships, I've received, mentorship as well. And I feel it's there. It's just we need to, try and be a role model to everyone. So that's why the Girl Scouts is so dear to my heart, because I feel like this is our way to reach out to them and let them know, you look like me, you can be a doctor, you can be an astronaut, you can be whatever you want to be. Ultimately, the support is there. It's unfortunately like we kind of need to pave the way and just kind of reach out and look for others like us to provide, that support.
That's great, Dr. Acosta. Thank you so much.
And we did have a question which Dr. Acosta kind of answered as far as describing experiences during your training where you were encouraged to continue and excel. So thank you for answering that question from the chat. And then we really don't have any other questions from the group. We've got, I had one, hold on, let me find, I had one in the email, which we kind of already discussed. One of the questions came from an attendee via email, which is more of a Girl Scout question. How's Girl Scouts helping within the community the prevention of COVID-19? And really, not really, in our role, we are, as far as Girl Scouts, we are a preventive organization, not an intervention nonprofit. And so we're not in a position to help as far as with direct services, as far as housing and food and critical needs like that. But we're expanding our programs to help more on the social and emotional learning outcomes that we know are kind of taking a toll now during COVID as well. So maybe we can wrap up with our final question to the panel around knowing that, especially for adolescents and girls, we serve girls in kindergarten through 12th grade. And we know that they've had some social isolation since spring break of last year. And there's just been so much uncertainty about going to summer camp, is it safe? Going back to school, is it safe? But can we maybe end today's panel discussion with just a quick conversation about the mental health for adolescents and for our girls, and maybe how they are adversely affected or things that we need to watch out for, and as an organization, what we can do together to really help our girls as we continue to recover from the pandemic.
So I guess I'll just say, as the psychologist of the group, that I think that COVID-19 has had isolating effects, and I think we know that there has been people are talking about the mental health pandemic that is maybe coming at us because of the isolation and just hardship that many have suffered. So, you know, I do think if girls are experiencing things like not doing the things that they normally enjoy, if they were kind of avid runners or avid, you know, into jigsaw puzzles and are no longer interested in those sorts of activities, if they are self-isolating and there is opportunity to socialize, if there's a change in appetite, a change in sleep, those are all indicators that perhaps more help needs to be sought. And it's important to, you know, keep our eye on our youth, and I know that we all do in the community as mothers and as parents. I do think that one of the great things that the Girl Scouts does, I was a Girl Scout, I don't know if that's public knowledge yet, but I was, and is the promotion of social norms and this idea that we are here for each other, we're here to support each other. There's a lot of connection. We were made for connection as humans. And so the prevention of kind of bullying and violence and things like that is one of those great things that I think the Girl Scouts kind of automatically provides by providing that kinship and fellowship amongst each other and with the emphasis on values. I'll stop there in case anybody else, anything else to add.
Anyone would like that? Thank you very much, Dr. Aguilar, for that. Anyone want to add anything? No? Okay. All right, well then with that, let's go ahead and close our event. I want to thank, on behalf of Girl Scouts, I want to thank Marilyn. Thank you so much for coming on board and helping to moderate this discussion. And then thank you to each of our panelists, Dr. Acosta, Dr. Aguilar, Dr. Morgan. You've brought so much insight today, a really great way to end this 4-part series. Just as a friendly reminder, we do, a lot of this stems from, this work that we're starting stems from our anti-racism pledge with Girl Scouts of the USA. So if you want to visit our website, we invite you to join us in taking that anti-racism pledge. This is just the beginning of work we're doing as an organization to really truly become an anti-racist organization. So this is not going to happen overnight. This is the first phase. And it really starts with education, right? Which is so much of what we've done today. So thank you very much. If you learned about something specific today that you want to share, the recording of this event is going to air. It's going to be played back on our social media channels on Saturday, this Saturday, October 3rd at 1 p.m. And you can find that link and watch that video at any time on our Facebook or YouTube channels. So I'll also send you a friendly reminder about that on Friday, so you'll get that link if you want to share that. And just thank you so much, everyone. Thank you to our volunteers and our attendees who have made time to listen every week. We've had several of you come in and join us every week. So thank you very much for that. And then if you look in the chat, we've got some thank yous from Marilyn to everyone, as well as from Angie, General Salinas, who is our CEO. Thanking everyone for participating. So with that, we will let you go. Enjoy the rest of your week, and best of luck as we work together to make the world a better place. That's the mission of Girl Scouts. So thank you so much, ladies.
Thank you. Good afternoon.